starting off with Section 1, normal scar maturation.
Now, a normal scar's maturation is an ongoing timeline, and it can actually take up to 18 months. Early on, so 0 to 6 weeks, these scars are highly vascular. They're red, raised, soft, and notoriously itchy, mostly because of all that rapid collagen synthesis. Then, moving into the intermediate phase, around 6 weeks to 6 months, collagen remodeling really takes over. The vascularity drops off, and the scar starts to flatten out and get paler. Finally, from 6 to 18 months, we arrive at the mature scar, which is pale, flat, soft, and significantly less vascular. Okay, there's one massive, super high-yield pearl you absolutely must commit to memory here: 80%. A healed wound never, ever regains 100% of its original strength. It caps out at a maximum tensile strength of about 80% of normal skin. Seriously, burn that number into your brain.
Moving right along to Section 2, abnormal scars defined.
First up, the hypertrophic scar. You can think of this as a sort of overzealous healing response. The absolute critical defining factor to remember is that the excess collagen is completely confined to the original boundaries of the wound. It gets raised, firm, and pink, often showing up just weeks after an injury, especially with burns or wounds that heal under tension. But there's a silver lining here. Because collagen production eventually winds down, hypertrophic scars actually have the potential to regress and improve entirely on their own over time. On the flip side, we have the keloid, which is basically an unchecked collagen factory. This is a benign fibroproliferative disorder where the excess collagen deposition aggressively extends way beyond the original wound margins. It creates these distinct claw-like projections invading the surrounding healthy skin. And this is all driven by persistent TGF-beta signaling, a protein pathway that promotes cell growth, meaning the collagen synthesis just keeps going unchecked. Because of this, keloids very rarely regress on their own, and they are notoriously tricky to manage.
All right, Section 3, hypertrophic versus keloid scars, the ultimate showdown.
When you look under the microscope, a hypertrophic scar neatly lines up its collagen in parallel bundles. It's got increased vascularity and numerous myofibroblasts, those cells that contract to pull wounds closed. But the absolute 5-star histological hallmark of a keloid, it's a chaotic, haphazard arrangement of thick, hyalinized bundles, often literally called keloidal collagen, and it's paired with very sparse myofibroblasts. It is just total structural chaos compared to the neat parallel order of the hypertrophic scar. Clinically, the contrast is super stark, and honestly, it's a goldmine for your exams. Just look at the breakdown. Keloids extend beyond the wound, they rarely regress, they have a frustratingly high recurrence rate, and they absolutely love to show up on earlobes, the sternum, and the deltoid. We also see them more commonly in dark-skinned individuals and young adults. Hypertrophic scars, though, they strictly stay put within the wound margins, they commonly regress, and they actually have a pretty low recurrence once the tension is removed. They're also famous for following severe burn injuries or popping up on flexor surfaces.
Let's jump into Section 4, the treatment arsenal.
For hypertrophic scars, our treatment algorithm starts off pretty conservatively. Step 1 is simply silicone gel or sheets. These hydrate the scar and tone down fibroblast activity. We pair this with pressure garments, which are absolutely critical, especially if the scar is from a burn. If symptoms are still hanging around, we step it up to Step 2, intralesional steroids like triamcinolone, or laser therapy to knock out some of that redness. We really only reserve Step 3, surgical revision, for the most resistant, carefully selected cases. Now, keloids, they demand a much more aggressive ladder. Step 1 for small lesions is silicone, paired immediately with the gold standard intralesional triamcinolone injections. For larger or more stubborn lesions, Step 2 is surgical excision. But, and this is a huge but, it must be paired with adjuvant therapy, like extra steroids. If a keloid keeps coming back after all that, Step 3 might involve radiotherapy for highly selected recurrent adult cases, mostly because it actively suppresses that rampant fibroblast proliferation. Putting these strategies side by side really makes it clear. Notice how silicone is your universal first-line defender across the board. Pressure therapy? Excellent for hypertrophic scars, but really only sometimes useful for keloids. Steroid injections are the gold standard for keloids. But the absolute most crucial takeaway here, the one you cannot forget, is this. Avoid treating keloids with surgery alone. Seriously, big red flag. We'll come back to exactly why that is so important in just a minute.
Finally, Section 5, exam pearls and MZQs. Let's test your knowledge. Pause for a second and think through this classic clinical presentation. You've got a 22-year-old woman with a progressively enlarging, itchy scar. And the keywords here, it's extending beyond the margins of an ear piercing.
If you guessed earlobe keloid, you nailed it.
Your first-line reflex for management here should always be silicone gel or sheets paired with an intralesional steroid, specifically triamcinolone acetonide. And if the examiner tries to trip you up and asks what to do if it's a massive lesion, your answer is surgical excision explicitly combined with adjuvant therapy.
Go ahead and lock these rapid-fire answers right into your brain. First line for most hypertrophic scars, silicone gel and sheets. The gold standard intralesional drug for keloids, triamcinolone acetonide. And where are pressure garments the most useful? Burn-related hypertrophic scars. Trust me, locking these specific pairings into memory is going to save you precious time on test day.
So, to distill the absolute most crucial takeaways from our entire explainer, we've established silicone as your primary weapon. We've linked the exact triggers. Burns equal hypertrophic scars, while ear piercings equal keloids. We've identified the histological hallmark you need to look for, which is haphazard kilonal collagen bundles, and we've named the cellular driver, persistent TGF-beta activation. And I want to leave you with this.
All right, Section 1, Causes and Risk Factors. Let's look at exactly how and why these ulcers form.
So what exactly is a pressure ulcer? In simple terms, it's a localized injury to the skin and the soft tissue underneath it, usually right over a bony prominence. It happens when you have prolonged pressure or pressure combined with what we call shear. Shear is basically when the skin is being pulled in one direction while the bone moves in another. This whole process literally starves the tissue of blood, leading to ischemia and eventually tissue necrosis or death. You've probably heard them called bed sores or decubitus ulcers, right? Well, biologically speaking, they are all the exact same process.
Now, I want you to pay really close attention to this specific number, 32 millimeters of mercury. This is absolutely crucial. It's your normal capillary closing pressure. The real trouble? It starts the very second external pressure applied to the skin exceeds this baseline number. Once you're sitting above 32 for an extended period, the tiny blood vessels feeding that skin are just pinched completely shut.
And when those vessels get pinched, things go bad pretty fast. Let's walk through this timeline of tissue death. At hour 1, you've got that prolonged pressure. Fast forward to hour 2, and we hit capillary occlusion. Those blood vessels are fully blocked. By hour 3, we're looking at ischemia, which is just the medical term for blood flow being totally cut off. No blood means no oxygen, bringing us to hypoxia at hour 4. And finally, by hour 5, we hit irreversible tissue necrosis, or cell death. It's a remarkably rapid, highly predictable cascade.
Now, obviously, not every single patient develops an ulcer in 5 hours. As you can see broken down in this table, the risk factors generally fall into 2 buckets: patient factors and hospital factors. On the hospital side, we see systemic issues, poor nursing care, infrequent repositioning, or maybe a really long surgery on a bad mattress. But let's evaluate the patient side. You've got age, diabetes, malnutrition, but the absolute most important patient risk factor overall, immobility. A patient who literally cannot move themselves, like someone with a spinal cord injury or a stroke or in a coma, they are at the absolute highest risk, hands down.
So where do these usually happen? Anatomical vulnerability varies heavily based on position. As this chart clearly shows, the sacrum takes the top spot overall, especially for patients lying flat on their backs. Think about it. The entire weight of the upper body acts like a mechanical vise, pressing that sacrobone heavily right into the mattress. But position really matters. The ischial tuberosities are incredibly common for sitting patients, like those in wheelchairs, and the greater trochanter, the side of the hip, takes all the brunt when a patient is lying in a lateral, side-lying position.
Moving right along to Section 2, Staging Pressure Ulcers. Let's figure out how we actually classify the tissue damage.
When we stage an ulcer, the physical depth of the wound is the whole shebang. It completely dictates the stage. Let's break this table down. Stage I is intact skin, but it has non-blanchable redness. That means if you press on the red spot, it stays red. It doesn't turn white. Stage 2 goes a bit deeper, with partial thickness loss. It honestly looks a lot like a blister. Stage 3 is full thickness loss, where you can actually see the subcutaneous fat. And Stage 4 is the absolute worst, full thickness loss that exposes the underlying bone, tendon, or muscle. Now there are 2 special caveats here. An unstageable ulcer is completely covered by dead tissue, called slough or eschar. You literally cannot see the bottom, so you can't stage it until it's cleaned out. On the flip side, a deep tissue pressure injury shows intact skin, but it has this dark purple or maroon discoloration. The skin isn't broken yet, but trust me, there is massive deep soft tissue damage lurking just beneath the surface.
Okay, Section 3, Diagnosis and Complications. What happens when things get advanced, and how do we investigate?
When these ulcers get incredibly deep, our biggest fear is a bone infection, known as osteomyelitis. Now, you might be tempted to just order a quick X-ray, right? Actually, scratch that. X-rays only detect really late stage changes in osteomyelitis. If you want the most sensitive, absolute gold standard for diagnosing an underlying bone infection, you need an MRI. For sure, if bone involvement is suspected, MRI is the answer.
If we look at the cellular breakdown, what do we see? Well, grossly, to the naked eye, we see necrotic tissue and slough, which eventually gives way to granulation tissue as the body desperately tries to heal. Microscopically, the initial acute injury shows inflammation and coagulative necrosis, which is just dead cells everywhere. But as that ulcer becomes chronic, the microscopic picture totally shifts. You start seeing a chronic inflammatory infiltrate, dense scarring or fibrosis, and neovascularization, which is basically the body's attempt to build brand new blood vessels to fix the area.
And if that chronic state isn't resolved, we run into some devastating complications. Osteomyelitis and sepsis can be rapidly fatal. Plus, all that chronic weeping from the wound leads to massive protein loss and malnutrition. But honestly, the most fascinating and dangerous complication is malignant transformation. Believe it or not, long-standing chronic pressure ulcers can actually mutate into squamous cell carcinoma. In this specific clinical context, we call that a Marjolin ulcer.
Which brings us to Section 4, treatment. Let's look at how we reverse the damage medically and surgically. For those early-stage ulcers, management is conservative. The absolute, non-negotiable cornerstone of treatment is pressure relief. You literally have to reposition the patient every 2 hours and use specialized air or foam mattresses. We also support their healing with a high-protein diet and zinc and keep the wound clean with basic saline. Now pay close attention here. Antibiotics are not routine, no way. You only use them if the patient actually has a systemic infection, like cellulitis or sepsis. We don't just throw antibiotics at an uninfected wound.
But what about stage 3 and 4 ulcers that completely fail conservative treatment? That's when the surgeon steps in following 4 exact steps. Step 1, radical debridement. They go in and cut away all the dead necrotic tissue. Step 2 is a bursectomy, to remove the bursa sac right over the bony prominence. Step 3, take out any underlying infected bone. And finally, Step 4, flap reconstruction. That's where they bring in fresh, healthy tissue with its own blood supply to permanently patch up the defect. And when it comes to those flaps, it's pretty neat. There's a direct, easy-to-memorize map connecting the anatomical site of the ulcer to the specific flap the surgeon will choose. If the ulcer is on the sacrum, the preferred choice is the gluteus maximus musculocutaneous flap. If it's trochanteric, meaning on the side of the hip, they'll use the tensor fasciolata, or TFL flap. Memorizing these direct mappings is a total game changer for understanding surgical planning.
Now, even after an ulcer finally heals, you're often left with a nasty, tight scar that can be really painful. So how do we revise that? Well, a Z-plasty is brilliant for this because it actually lengthens a contracted scar, giving the patient their mobility back. A W-plasty is used a bit more for cosmetic improvement. And in really extreme cases, we might need a full skin graft, a local flap, or even tissue expansion to get things fully restored.
All right, home stretch. Section 5, high-yield exam pearls, the absolute must-know facts.
Let's do a quick rapid fire and test your retention with some multiple choice questions pulled straight from our sources. Seriously, I highly encourage you to pause the explainer right here and test yourself. Okay, what is the most common site overall? The sacrum. What is the most important factor in formation? Prolonged pressure. What's that magic capillary closing pressure? Yep, 32 mmG. And what is the absolute best imaging for osteomyelitis beneath an ulcer? It's got to be the MRI. To summarize the absolute non-negotiable facts you need to take away from this, lock these into your brain. Pressure exceeding 32 millimeters of mercury is what causes the ischemia. The sacrum is the top site, but always watch out for the ischial tuberosities in wheelchair users. MRI is your go-to for bone infection. Stage 3 and 4 need surgical debridement and flaps. And please, never forget that chronic ulcers can undergo malignant transformation into squamous cell carcinoma, the Marjolin ulcer.
Section 1, the skin graft basics. So what actually is a skin graft? Well, by definition, it's a segment of skin that is transferred to a recipient bed. But here is the absolutely crucial key word: completely detached. Once you transfer that tissue, it has zero intrinsic blood supply. I mean, it doesn't bring a single functioning artery or vein with it. None. It relies entirely, 100%, on its new home, the recipient bed, to establish a new vascular connection. Without that new bed stepping up, the tissue simply cannot survive. And because it relies so heavily on its new home, the quality of that home is literally everything. This perfectly highlights where grafts thrive versus where they're basically doomed to fail. On the left, we've got our excellent recipient sites, healthy granulation tissue, muscle, fascia, and periosteum, all with an intact blood supply. What's the common denominator here? They are highly vascular. Now look at the right, the poor sites, bare tendon, bare cortical bone, cartilage without pericandrium or irradiated tissue. These are avascular deserts. Trying to put a skin graft here is literally like planting a seed on solid concrete. It's just not going to take. So for this incredibly delicate tissue to actually survive, a few exact conditions have to be met perfectly in that recipient bed. You absolutely need adequate vascularity and healthy granulation tissue, sure, but you also need a totally pristine environment. That means absolutely no infection and no hematoma or seroma. Fluid buildup just creates a physical wall between the graft and the blood it so desperately needs. Finally, firm immobilization and good contact are strictly required. Think about it. If the graft shifts around even a little bit, those tiny, fragile new blood vessels that are trying to connect, they'll just shear right off.
Moving on to Section 2, Classifications and Sources.
So we can classify grafts by where we actually get them from. The autograft, which is tissue taken from the exact same patient, is for sure our permanent gold standard. Because it's the patient's own tissue, there's no immune rejection to worry about. Isografts, which come from an identical twin, also share this permanent status. But then we have allografts, from a different human individual, and xenografts, which come from a completely different species like a pig. These just act as temporary biological dressings. Why? Because the body's immune system will eventually realize they're foreign and reject the whole shebang. Now, when we classify split-thickness skin grafts, or STSGs, by their thickness, you'll notice they always contain the entire epidermis, but only a variable or partial chunk of the underlying dermis. They range from thin to thick, anywhere from 0.15 to 0.60 millimeters. And there's a really important dynamic you've got to remember here. Thicker grafts are going to give you much better functional results, but they also demand a way richer blood supply from that recipient bed. Make sense? There's simply more tissue you have to keep alive.
Let's jump into Section 3, the STSG versus FTSG comparison.
When you're standing there choosing between a split thickness and a full thickness graft, it's all about trade-offs, right? A full thickness skin graft, or FTSG, takes the entire epidermis and the entire dermis. Now, STSGs, because they're thinner, have a much more reliable graft take. They just need less blood, which is awesome because it lets us cover massive surface areas. The downside, they have a lot of secondary contraction and honestly, only fair cosmetic outcomes. FTSGs, on the flip side, offer excellent cosmetic results, way higher durability and minimal contraction. But because they're so thick, their graft take is less reliable, they demand a perfectly pristine vascular bed, and you're pretty much limited to covering smaller defects. So how does this play out in practice? Well, because STSGs can reliably cover vast, huge areas. They literally save lives when dealing with extensive burns, large traumatic wounds, and chronic ulcers. Meanwhile, FTSGs are your absolute go-to for restoring delicate aesthetics and functional durability to specific, highly visible or mobile spots. We're talking the face, eyelids, nose, lips, and fingers. Those are places where severe secondary contraction from an STSG would cause pretty terrible deformities.
All right, Section 4, Evaluating Donor Sites.
The massive takeaway to remember here is how the donor site heals based on how much tissue we actually took. With an STSG, because we intentionally leave a portion of the dermis behind at the donor site, it heals completely spontaneously. The lateral thigh is the classic spot for this. But for an FTSG, we are harvesting the entire dermis all the way down to the subcutaneous fat. That donor site simply cannot heal on its own. So FTSG donor sites, like the postauricular area behind the ear or the groin, must be surgically stitched up and closed primarily. Section 5, the timeline of graft take. Let's chronologically trace a graft from its initial desperate fight for survival to the point where it forms entirely new circulatory networks. First up, for the first 24 to 48 hours, we have plasmatic imbibition. Then, right around the 48 to 72-hour mark, we hit inosculation. This is where capillaries from the recipient bed finally start to physically plug into the existing vessels in the graft, and early circulation kicks off. Finally, from day 3 onward, we have revascularization. This is where entirely new blood vessels grow deep into the graft, eventually followed by the regeneration of lymphatics and nerves. I want to pause on that first critical stage for a second, plasmatic imbibition, because it is absolutely fascinating. For the first 2 days, this tissue survives without a single drop of flowing blood. Instead, it acts exactly like a sponge. It just drinks up local wound fluids, nutrients, and oxygen directly from the exudate of the recipient bed. If that bed doesn't produce this nutrient-rich fluid, or if there's a physical barrier in the way, like a hematoma blocking our little sponge, the graft literally starves to death before it ever has a chance to connect. Let's bring it home with Section 6, High-Yield Exam Pearls. Let's run through the exact types of multiple-choice questions you are definitely going to encounter. Ready? What's the gold standard graft? The autograft. What is the absolute best choice for extensive burns? The split-thickness skin graft, because of its reliable take over huge areas. What exactly makes up an FTSG? The epidermis plus the entire dermis. What is the very first phase of graft survival? Plasmatic imbibition. And lastly, which graft shows the greatest secondary contraction? Again, that's going to be your split-thickness skin graft. Furthermore, you've got to always remember the cardinal rule for your Viva examinations. A graft has no original blood supply. It is completely 100% severed. A flap, on the other hand, retains its original blood supply as it's being moved. Also, you need to firmly commit those 3 stages of take to memory: imbibition, inosculation, and revascularization. That sequence is hands down one of the most commonly tested concepts in the entire curriculum. So let me ask you a classic Viva question right now, just to test how well we've absorbed today's foundational rule. Based on everything we just talked about regarding how a graft actually survives, why would it fail on bare cortical bone or a bare tendon? Take a quick second to think about that. The answer is beautifully simple. Skin grafts do not survive on avascular surfaces. Bare bone and bare tendon simply do not have the blood supply required. If you don't have an underlying vascular network to produce that nutrient-rich exudate for plasmatic imbibition, and you don't have capillaries to connect during inosculation, the grafted tissue just starves and dies. It absolutely demands that rich vascular bed.
Let's jump right into Section 1, harvesting skin grafts and extracting that donor tissue.
So when you're harvesting a split-thickness skin graft, an STSG, you have to follow a pretty strict sequence. You prep and drape aseptically, right? But step 2 is where a lot of people trip up. You absolutely must apply mineral oil. Why? Well, because next you're using a dermatome, which is essentially a highly precise surgical shaver. That mineral oil reduces friction so the blade just glides, giving you this perfectly smooth, continuous cut before you apply the graft and finally dress the donor site.
Now check out how differently these 2 donor sites heal, depending on what you actually extract. On the left, we've got a split-thickness graft. Here, you're leaving the deep dermis behind, so it heals spontaneously in about 10 to 14 days, literally just re-epithelializing from the leftover hair follicles and sweat glands. But look at the full-thickness graft on the right. You're taking everything. That leaves an open wound that requires primary closure with sutures. Plus, and this is a big one, you have to meticulously defat the graft. You scrape all that subcutaneous fat off because fat acts like a physical roadblock to new blood vessels. Moving right along to Section 2, meshed versus sheet grafts and choosing the right format.
As you can see in this table, being in the OR means facing a constant trade-off between function and aesthetics. If you're dealing with an extensive, weeping burn, you're going to run that graft through a mesher. This creates these tiny slits, right? It lets the skin expand, sometimes up to 6 times its size. But crucially, as the table shows, those holes give you excellent fluid drainage, keeping your hematoma risk incredibly low. The catch, of course, is that it heals looking exactly like a mesh, so poor cosmetic appearance. Now, if you're working on the face or hands, you're going with a sheet graft. The cosmetic result is excellent, but since it's a solid sheet, trapped fluid has nowhere to drain, which significantly drives up your risk of a graft-killing hematoma.
All right, Section 3, graft survival and failure, specifically the triad of take.
Think of a fresh skin graft like a parasite. It brings absolutely zero blood supply of its own, so it relies entirely on the recipient bed. Now, a favorable bed, that's one packed with healthy granulation tissue, fantastic vascularity, and complete hemostasis. But what happens if you place a graft on an unfavorable bed, like a bare tendon, bare cortical bone, necrotic tissue, or radiation injury? Well, that is literally like planting seeds on concrete. Those tissues are hypovascular, so without an underlying blood supply to feed it, the graft is just going to starve and die.
And when we talk about graft failure, there is one massive, #1 threat that stands above all the rest in those critical first 72 hours.
Looking at this chart, you can clearly see hematomas is the absolute king of graft loss. It's that massive slice right there. A hematoma is just a collection of blood, but if a pool of blood forms between your new graft and the recipient bed, it physically separates the skin from its only source of oxygen. It essentially suffocates the graft. The other common culprits make up the rest of the pie. Infection, especially Pseudomonas, shearing forces that rip those tiny new blood vessels apart, a hypovascular bed, and finally high thickness or poor defatting.
So how do we stop that? That brings us to Section 4, fixation and postoperative care, and how we actually secure the graft.
Since hematoma and shearing are our biggest enemies, we really have to lock that graft down tight. Enter the tie-over dressing. This is arguably the most common VIVA question you're going to face. Basically, you place a non-adherent dressing over the graft, stack a cotton or foam bolster on top of that, and then you literally tie the surgical sutures directly over the bolster to squish the whole thing down. It acts just like a physical clamp. It applies uniform pressure, completely eliminates that dead space where blood could pool, and stops the graft from shearing.
Let's walk through this timeline, because in the days following surgery, strict rules apply. At day 0, it's all about strict immobilization and elevating the limb to reduce swelling. You leave that tie-over dressing completely alone. No peeking, or you seriously risk shearing the graft. It isn't until day 3 to 5 that we safely do the first dressing change to check the take. Fast forward to day 10 to 14, and your STSG donor site should be fully healed. And finally, looking a month or more out, we begin late post-operative physiotherapy. That is absolutely vital for grafts over joints so you can prevent permanent stiffness.
Moving on to Section 5, complications and indications. Basically, when to graft and what can go wrong.
So, you're going to use skin grafts to solve a few major clinical problems. You've got acute defects, like extensive burns, traumatic skin loss, or post-excision defects from something like cancer removal. Then you have chronic issues, like venous ulcers, pressure sores, or diabetic foot ulcers, after debridement, of course. But the golden rule for every single one of these indications, you must achieve healthy, infection-free granulation tissue before you even think about placing that graft. Now, despite our best efforts, things can and do go wrong. We divide these into early and late threats. Early complications strike within the first week and threaten the survival of the graft itself. We're talking hematomas, seromas, which is clear fluid instead of blood, infections, partial graft loss, and bleeding. Late complications, on the other hand, develop over months and really threaten the patient's quality of life. The graft might undergo contracture, literally shrinking down and restricting movement. You might also see pigmentary changes, hypertrophic scarring, or chronically poor sensation.
All right, let's wrap this up with Section 6, high-yield exam pearls for MCQ and Viva Mastery.
I've mapped out the most frequent multiple-choice questions right here in this table. Let's rapid-fire through them. If you're asked for the absolute most common cause of graft failure, instantly answer hematoma. The best option for extensive, weeping burns? Meshed STSG, thanks to that fluid drainage. The most common securing dressing? The tie-over dressing. And the greatest threat in those first 72 hours? You're looking for the combined answer of hematoma and shearing.
And for your oral boards or IMM exams, these are the clinical takeaways you absolutely cannot miss. If an examiner asks how to guarantee graft survival, you hit them with the triad of success: a healthy recipient bed, meticulous hemostasis, and complete immobilization. For donor care, remember that stark contrast. FTSG donor sites require primary closure, while STSG sites heal via spontaneous re-epithelialization from skin appendages.
Starting right off with Section 1, graft versus flap. Let's start with the absolute basics. A flap is defined as a unit of tissue transferred from one site to another while maintaining its own blood supply. Now, why does that matter? Well, unlike a standard skin graft, a flap essentially brings its own power generator rather than relying on the local power grid of the recipient bed. It absolutely doesn't depend on the new site for its initial survival. It does this either through an intact vascular pedicle or by surgeons literally hooking up the vessels directly under a microscope. It's pretty amazing. This fundamental difference is a massive Viva favorite for a reason. Think of a graft as simple but totally dependent. It has no intrinsic blood supply and relies entirely on the vascularity of its new home. A flap, on the other hand, retains its own blood supply. Because flaps bring that independent vascularity, they can survive over poorly vascularized areas, giving us a way to cover things like bare tendon or bone. Sure, it definitely makes the procedure a lot more complex, but for those difficult reconstructions, it's absolutely necessary. So why would a surgeon choose this complex procedure over a simple graft? Well, a graft simply cannot survive on bare avascular surfaces. Think exposed bone, tendon, or joints. They just won't make it. Plus, if you have exposed vessels and nerves, you need thick, reliable coverage to properly protect them.
And in really challenging situations like irradiated tissue or osteomyelitis, the local blood supply is just way too compromised to ever support a standard graft. So the golden rule here, the real clinical pearl to remember, is that bone, tendon, and hardware demand a flap, not a graft.
Moving right along to Section 2, the blood supply blueprint.
Let's look at the chronological timeline of flap survival. Initially, right during the transfer phase, you absolutely require independent arterial inflow. You have to bring in that oxygenated blood. But as we move into the second phase, survival actually hinges heavily on venous drainage. You must get the deoxygenated blood out to prevent congestion. In fact, venous congestion is literally the most common cause of flap failure. Finally, in the late stage, the lymphatic drainage eventually returns to the tissue to normalize everything. Now, when we classify flaps by their blood supply, and by the way, this is the most important classification you can make, we're really looking at random pattern versus axial pattern flaps. A random pattern flap gets its blood merely from the subdermal vascular plexus. There's no specific named artery doing the work. But an axial pattern flap, that is supplied by a direct named artery. A classic example is the forehead flap, which is super reliably supplied by the supratrochlear artery. And that difference is exactly why axial flaps are considered the heavy lifters of reconstruction. A random flap is perfectly fine for small defects, but it's really limited in size because of that generic blood supply. The axial flap, however, shoots way up in both reliability and potential size. Having a named, direct artery constantly pumping into the tissue just gives the surgeon so much more reliable real estate to work with. It's a total game changer. Okay, Section 3, Classifications and Tissue Types. The modularity of flaps is honestly incredible. You can have a basic cutaneous flap, which is just skin, or you can add fascia to create a fasciocutaneous flap, giving you a great blood supply that's super common in limb reconstruction. Need something for an infected wound? Pure muscle flaps are excellent for that because of their rich vascularity. Or you can even combine muscle and skin. We also have osteocutaneous combos, literally bone and skin, for really complex jobs like rebuilding a jaw. And brilliantly, we have perforator flaps. These take the skin and perforating vessels, but preserve the underlying muscle, which massively reduces morbidity at the donor site. We can also break down flaps simply by where they come from. A local flap just moves tissue right next door to the defect. It gives an excellent color match and is usually a one-stage reconstruction. Then we have a regional flap, pulled from the same general anatomical area. Distant flaps are often stage transfers from a completely different part of the body, like a cross-leg flap. And finally, the absolute pinnacle of complexity is the free flap. This involves completely detaching the tissue and meticulously reconnecting the blood vessels under a microscope, like you'd see with a radial forearm free flap.
Section 4, Local Flap Mechanics.
Let's talk about how this tissue actually moves. The mechanics are pretty straightforward once you picture them. Advancement flaps just push directly forward in a straight line, right into the defect. Rotation flaps, on the other hand, use a semicircular pivot, kind of swinging around a central point. And transposition flaps essentially jump diagonally across a piece of intact, normal skin to reach their final destination.
Section 5, Principles of Flap Design.
Now, how do we make sure a flap actually survives? There are 4 absolute essential principles here. First, preserve the vascular pedicle and handle the tissue very gently. Second, ensure adequate length because tension is the ultimate enemy of blood flow. Third, whatever you do, avoid twisting or kinking that vascular lifeline. And fourth, achieve meticulous hemostasis while ensuring you don't compress the flap with tight dressings. Because look, even the most brilliantly planned flap will fail immediately if that pedicle is twisted or stretched too tight. All right, let's wrap things up with Section 6, High-Yield Exam Pearls and MCQs. Let's rapidly review some of the most highly tested concepts. First up, how does a flap actually differ from a graft? Remember, it maintains its own blood supply. Next, what is the blood supply of a random flap? That would be the subdermal vascular plexus. And what's the most reliable flap? The axial pattern flap, all thanks to that direct, named artery. Getting these down really cements those fundamental differences in vascularity we talked about earlier. Moving to our next batch of questions, what's the best reconstruction for an exposed tibial bone? Remember the pearl. Bone needs a flap, not a graft. Next, what does a free flap require? Microvascular anastomosis, which means surgically sewing those tiny vessels together under a microscope. And finally, what is the most common cause of flap compromise? Venous congestion. Honestly, recognizing venous congestion quickly is probably the most critical post-op skill any surgical trainee can possess to save a failing flap.
Let's lock in some absolute must-know facts for your exams. Flaps are always indicated for exposed bone, tendon, joints, vessels, and nerves. Local flaps, those advancement, rotation, and transposition ones, are consistently highly tested. And lastly, perforator flaps are incredibly prized in modern surgery because they preserve that underlying muscle function, vastly reducing donor site morbidity. Take a mental snapshot of these, they are essential. All of this brilliantly illustrates...
All right, Section 1, Physiology and Flap Delay. This is all about setting the stage for survival. So, the fundamental truth of any flap surgery is that tissue survival is completely dependent on a delicate, almost perfect balance. You need adequate arterial blood flowing in, adequate venous blood flowing out, and a perfectly intact microcirculation right in between. Without those three things, the tissue simply won't survive the transfer. To make sure this happens, we use a counterintuitive concept known as the delay phenomenon. Now, imagine intentionally cutting off part of the blood supply to a piece of tissue you're trying to save. Sounds a bit crazy, right? But by strategically interrupting part of that supply before the main surgery, we actually force the remaining blood vessels to adapt, enlarge, and just become more robust. We're essentially stressing the tissue in a totally safe, controlled way so it's tough enough to survive the big move later on.
And you can see exactly how that delay process unfolds over time right here. On day 0, the surgeon makes the initial cut to partially interrupt the blood supply. Then, over the next 7 to 21 days, something amazing happens biologically. The existing choke vessels dilate, and angiogenesis kicks in, which just means entirely new blood vessels start to grow to compensate. By day 21 and beyond, the flap has this supercharged, highly reliable vascular network, making it incredibly safe to transfer. It's an absolute game changer, especially for long flaps or for high-risk patients with compromised microcirculation, like smokers or folks with irradiated tissue.
Moving on to Section 2, the critical monitoring period. This is where the clock officially starts ticking.
Once that flap is transferred, the real stress test begins. We're entering the post-operative phase, where extreme vigilance is literally the only thing standing between surgical success and devastating tissue death. The clock is ticking, and the most crucial point is this number right here, 72. The first 24 to 72 hours are the absolute most critical window for monitoring a flap. If the plumbing's going to fail, or if a clot is going to form, it is highly likely to happen during this specific time frame.
Now, a super simple bedside test can immediately tell us what's happening inside the flap's microscopic plumbing, and that's capillary refill time. If you press on the tissue and release, normal refill takes about 1 to 2 seconds. But check out the extremes. If the refill is lightning fast, under a second, it means blood is pooling because it can't get out. That's venous congestion. On the flip side, if the refill is sluggish, taking 3 seconds or more, or if it's completely absent, blood isn't getting into the flap at all. That points straight to arterial insufficiency.
Before we get into what goes wrong, let's establish the baseline for a perfectly healthy, happy flap. You want the color to be a healthy pink, it should feel warm to the touch, the turgor, or the tissue tension, should be soft, definitely not swollen or hard. If you do a pinprick test with a needle, you should see bright red oxygenated blood. And finally, using a handheld Doppler, you should hear a strong, audible swoosh of arterial flow. That one's especially vital for monitoring free flaps.
Section 3. Flap Failure. Arterial versus venous. Time to diagnose the danger. So what actually happens when those signs start to change? Let's break down the two main villains. Poor inflow, which is an arterial problem, versus poor outflow, which is a venous problem. Look at this comparison. If a flap has an arterial issue, meaning blood isn't arriving, it essentially starves. It turns pale, it feels cold, the capillary refill is noticeably delayed, you get zero bleeding on a pinprick, and there's minimal swelling because, well, nothing is entering. But contrast that with a venous issue. Blood gets in, but it can't drain out. The flap becomes totally choked. It turns a bruised blue or purple color. Interestingly, it might actually feel warm initially because arterial blood is still pumping in. The refill is super rapid, the pinprick yields dark, deoxygenated blood, and the tissue becomes markedly swollen and tense.
I really want to highlight this fact because it's so important. While it's super easy to obsess over the arteries, venous congestion is actually the most common cause of flap compromise. Venous drainage is just as critical and, practically speaking, it's way more likely to cause problems. The veins are thinner, they're more easily compressed, and they are highly prone to kinking.
So how do we actually rescue these failing flaps? Well, for arterial insufficiency, you immediately remove any tight dressings, fix the flap's physical position, treat for vasospasm, and if you suspect a clot, that's an urgent, immediate return to the operating theater.
For venous congestion, you also loosen the dressings and fix any pedicle kinking. But here is where it gets incredibly fascinating. Medicinal leeches, seriously. In selected cases where venous outflow is hopelessly compromised, surgeons will literally attach leeches to the flap. The leeches actively drain the pooling venous blood and secrete natural anticoagulants. They act as a temporary biological drain until the flap can grow its own new venous connections. It's a lifesaver.
All right, Section 4, Complications and Clinical Uses. Let's talk about some real-world applications.
Let's pull back and look at the broader picture. Beyond that immediate critical period, what other hurdles exist? Surviving the first 72 hours is huge, but surgeons have to anticipate other complications. Early on, they're watching out for hematomas, which are collections of blood, or seromas, which are collections of fluid. Infection and partial tissue necrosis are always risks on the table, as is wound dehiscence, which is where the surgical incision splits open. Then you have late complications. These happen weeks or even months down the line, and can include tissue contracture, an overly bulky flap that needs to be thinned out, poor cosmetic contour, or sensory loss. And of course, we can't forget the donor site, the place where the flap was taken from. Managing donor site morbidity is an absolutely crucial part of the overall surgical plan.
Now, when it comes to chronic issues like pressure sores or diabetic foot ulcers, you can't just slap a flap over a dirty wound and hope it holds. There is a very strict logical sequence. Step 1 is always pressure relief and aggressive surgical debridement of any dead tissue. Step 2 is total infection control. Step 3, and this is particularly important for diabetic feet, is revascularization. You have to ensure the leg itself has enough blood flow to support healing. Only after those 3 steps are fully completed do we even arrive at Step 4, which is the actual flap coverage.
Just to give you a sense of scale, let's take a rapid tour of the body to see where these are used. For head and neck cancers, where let's say the jawbone is removed, surgeons often use a fibular flap from the leg. For lower limb traumas with exposed tibia bones, local muscle flaps, like the gastrocnemius, are literal limb savers. For deep sacral pressure sores, the gluteus maximus flap is heavily relied upon. And for breast reconstruction post-mastectomy, flaps utilizing back or abdominal tissue, like the latissimus dorsi or dia EP flaps, are considered the gold standard.
Finally, Section 5, High-Yield MCQs and Pearls. Let's test your knowledge.
Huge congratulations on making it through the core theory. Let's do a quick mental reflex test using the scenarios on screen. First, how does flap delay actually improve survival? By dilating those choke vessels and prompting angiogenesis. What is the most common cause of flap compromise? Venous congestion. If you see a blue, swollen flap with lightning-fast capillary refill, what is it? Again, venous congestion. What if it's a pale, cold flap with delayed or completely absent refill? That's going to be arterial insufficiency. And finally, what is the absolute most critical period for monitoring? Yep, the first 72 hours.
Let's wrap this up with some top-tier exam pearls to really lock it in. First, remember the golden rule of reconstruction. Flaps bring their own blood supply, while grafts completely rely on the wound bed. Because of this, flaps and never grafts are strictly required whenever you're dealing with exposed bone, tendon, joints, or metal hardware. Second, know your threat levels. Venous congestion happens most frequently, but an arterial thrombosis is typically your most limb-threatening emergency. And lastly, always fall back on the 5 clinical parameters of monitoring: color, temperature, capillary refill, turgor, and pinprick bleeding.
We have covered a tremendous... To fix this machine, we really have to map out those mechanical cables to understand how the hand closes. The absolute most crucial point here is knowing exactly where these flexor tendons insert, because that physical insertion point dictates exactly how we test them when things go sideways. So, the flexor digitorum superficialis, or FDS, stops at the middle phalanx to flex the pip joint. That's basically just your middle knuckle. But the profundus, the FDP, completely bypasses that middle knuckle and goes all the way down to the distal phalanx to flex the DIP joint, the very tip of your finger. Understanding that separation of labor is literally the key to every single physical exam of the hand.
Now, what actually happens when one of those cables snaps? It's not magic. It follows a very rigid biological timeline. Day 0 to 5 is the inflammatory phase. A hematoma forms to jumpstart the whole process. Then, bridging the gap up to about 4 weeks, you hit the proliferative phase. Fibroblasts rush in to lay down type 3 collagen. Honestly, you can just think of type 3 collagen as a quick, kind of messy biological scaffolding. It gets the job done fast, but it's weak. Finally, over weeks to months, the remodeling phase kicks in. That early scaffolding gets broken down and replaced with much stronger, highly durable type 1 collagen,
transforming that repair into a dense cable that can actually handle daily life.
Moving right along to Section 2, flexor and extensor injuries, or what happens when those cables snap.
So when a patient comes in with a laceration, the specific anatomical zone of that injury completely dictates your surgical approach. And there's one specific zone that surgeons universally dread. We call it no man's land, officially Verdun Zone 2. This stretches from the distal palmar crease, right at the base of your fingers, up to that FDS insertion at the middle knuckle. The reason it's so terrifying is that both the superficial and deep tendons are crammed together tightly into a rigid fibroosseous sheath. It's a biological tunnel with zero wiggle room. If you try to fix a severed tendon here, even a single millimeter of excess scar tissue will glue the tendons right to the tunnel wall, totally freezing the finger. It's a true technical nightmare.
Before you ever bring a patient into the OR, you need to know exactly what's broken. And you do that by isolating the mechanics step by step. To test the FDS, you physically hold the patient's adjacent fingers completely straight and locked out. This essentially inactivates the deep tendons. Then, you just ask them to bend their middle knuckle, the PIP joint. Pretty cool, right? To test the deeper FDP tendon, you hold their middle phalanx steady and see if they can bend just the very tip of the finger. It's just pure, elegant biomechanics.
Things get just as fascinating when we flip to the back of the hand. Understanding these counterintuitive extensor mechanics explains some pretty dramatic visual deformities. Take a central slip injury, for example. When that central slip tears, it pulls the middle knuckle into hyperflexion while hyperextending the fingertip. We call this a boutonniere deformity, from the French word for buttonhole, because the joint literally pops through the split tendon like a button through a shirt. On the flip side, chronic issues like rheumatoid arthritis weaken the palmar stabilizing ligaments, creating a swan neck deformity. This is the exact mechanical opposite. The middle knuckle violently hyperextends backward, and the fingertip drops downward.
Let's transition to Section 3, nerve and fingertip damage. We've got the mechanical cables down, so now let's look at the electrical wiring and the padding.
This mapping is a massive high-yield pearl for anyone in clinical practice. You've got to seamlessly link the big three nerves to their specific motor deficits. If you damage the median nerve, the thenar muscles at the base of the thumb fail. That gives you an ape thumb, where you totally lose the ability to cross your thumb over your palm, basically turning the hand into a flat paddle. Ulnar nerve damage, that paralyzes the intrinsic interosseous muscles. Without them, the fingers curl up into a profound claw hand. And if you sever the radial nerve, the forearm extensor muscles just completely fail. Gravity takes over, and boom, you get a classic wrist drop.
So what about the very end of the line, the fingertips? These are super common injuries, and how you handle them depends entirely on the soft tissue loss and if the underlying bone is exposed. Depending on the defect's geometry, you might just do a primary closure, maybe a skin graft, or you might need some complex tissue rearranging. A great example of this is the VY advancement, also known as an Ottosoy flap. You essentially cut healthy local tissue in a V shape, physically push it forward to cover the bone and suture it closed into a Y shape. We use these incredibly precise techniques because we have to preserve two non-negotiable things: functional length and essential fingertip sensation.
All right, Section 4, infections and compartment syndrome. These are your true, no messing around, surgical emergencies.
Sometimes the biggest threat isn't a cut, but pressure and pus inside the closed spaces of the hand. And there's a legendary clinical checklist for this, Knavel's 4 cardinal signs. If a patient comes in and their finger has fusiform swelling, meaning it looks uniformly puffy, honestly just like a sausage, and they're protectively holding it in slight flexion, it's tender along the whole tendon sheath, and they have screaming severe pain when you try to passively straighten it, stop immediately. You are looking at pyogenic flexor tenosynovitis. It's a devastating closed-space infection that just eats tendons. It demands urgent IV antibiotics and usually an immediate trip to the OR for drainage.
Speaking of intense pain on passive stretch, that is also the classic hallmark of our next emergency, compartment syndrome. This can be triggered by a crush injury, a bad fracture, or literally just a cast that's wrapped way too tight. The pressure inside the rigid fascial compartments of the hand starts to rise, and that fascia acts like a biological straitjacket. It just chokes off the arterial blood supply. The absolute crucial takeaway here: the only fix is an emergency fasciotomy. You have to slice open those compartments to relieve the tension before the nerves and muscles die permanently. Time is tissue.
Now for Section 5, replantation rules and guidelines. Let's talk about how we rebuild the machine when the worst happens. When an amputation occurs, modern microsurgery can actually step in and reattach the parts. But this relies on pure mechanics and priority. Get this, your thumb alone is responsible for 50% of your entire hand's function.
Because of its totally unique joint, it swings across the palm to enable pinch and grasp. Without it, the hand is basically just a hook. That is exactly why replanting a severed thumb is always the absolute highest priority for a surgeon, no questions asked.
But time is always ticking, right? The concepts of warm versus cold ischemia times are so critical here. Digits actually survive without blood flow way longer than you'd expect, mostly because fingers don't have much actual muscle belly, and muscle is what degrades the fastest without oxygen. A severed finger can tolerate up to 12 hours of warm ischemia at room temperature. But if you wrap it properly and put it on ice, it can tolerate an unbelievable 24 hours of cold ischemia. It literally sounds like science fiction, but knowing those countdowns is how we know if replantation is even biologically possible.
The rules for when to actually do this are pretty stark. We definitely replant for thumb amputations, virtually any amputation in children, because their healing potential is just off the charts, and for multiple digits, especially if it's a clean guillotine cut where the vessels are sliced neatly. But the contraindications, they are absolute. If it's a severe crush injury where the delicate lining of the blood vessels is totally destroyed, or if there's prolonged warm ischemia or heavy contamination, replantation will fail. If you force it, you're looking at thrombosis, and you could even trigger toxic shock and threaten the patient's life.
All right, let's wrap this up with Section 6, high-yield MCQs and pearls. It's time for the exam room cool-down.
We've covered a ton of ground, so let's lock in the no-miss data. Visual recognition is absolutely everything. Let's do a rapid-fire match of these classic deformities. Drooping fingertip joint that the patient physically cannot lift, looking like a hammerhead, that's a mallet finger. Middle knuckle flexed down and the fingertip hyperextended upward, lock it in. That's a central slip injury, giving you the boutonniere deformity.
Moving into some literal exam gold here. If they ask you about no man's land, immediately think of flexor tendon zone 2 and that unforgiving fibroosseous sheath. What's the single most important digit to replant? The thumb, always. And if you see a prompt with fusiform swelling and excruciating pain on passive extension, those are Canaveral signs, pointing straight to pyogenic flexor tenosynovitis.
Keep the momentum going. The non-negotiable emergency treatment for compartment syndrome is a fasciotomy. You do not wait for a scan. You cut the compartments open to save the tissue. And if you see a patient with a claw hand where the fingers are rigidly curled in, you immediately know the ulnar nerve was cut. The intrinsic muscles lose power and the claw takes over.
Let's finish with the ultimate surgical fix. Meticulously repairing those flexor tendons requires the gold standard technique, the modified Kessler core suture, combined with a running epitendinous suture around the outside. The Kessler basically locks the core so the tendon doesn't gap open when it's under tension. But here's the real magic. You have to pair that brilliant repair with early controlled mobilization. By making the tendon glide gently within the first few days, you physically stop scarred tissue from gluing it to the tunnel wall. That is how you give a patient the best possible chance at getting their hand back.
So we've mapped out the entire... First up, let's define exactly what we are dealing with here. Basically, a cleft lip or a cleft palate is a congenital craniofacial anomaly, and it happens when embryonic facial processes just fail to fuse during early fetal development. But listen, here is the absolute must-know medical pearl to lock in right now. Cleft lip and cleft palate actually have completely different embryological origins. I mean, sure, they can present together in the same patient, but they can also occur completely independently of one another.
You know, understanding the exact timeline of these defects is basically a cheat code for nailing your Viva questions. So, lip development happens first. We're talking between the 5th and 7th week of gestation. This requires 2 medial nasal processes and 2 maxillary processes to fuse. If that fails, you get a cleft lip. Now, palate development happens a bit later, right between the 7th and 12th week. This requires the right and left palatine shelves, which, fun fact, are actually outgrowths of the maxillary processes, to fuse. Disrupt that later timeline, and boom, you've got a cleft palate.
So what's actually causing this disruption? Well, it's definitely multifactorial. On one hand, you've got genetic factors. This could be a family history or syndromic associations. Think Pierre-Robin sequence or Vanderwood syndrome. On the other hand, we have environmental culprits. These are maternal factors like smoking, alcohol, folate deficiency, diabetes, and exposure to specific teratogenic medications. Specifically, watch out for retinoic acid and anti-epileptic drugs like phenytoin and valproate.
Moving right along to Section 2, Anatomy and Classification. Let's see how this actually looks physically.
When we compare the anatomy, the differences are pretty stark.
A cleft lip involves the outer structures, the skin, the orbicularis oris muscle, the vermilion border, the nasal floor, and sometimes the alveolus. A cleft palate, though, that strikes way deeper. It involves the hard and soft palate, the uvula, and, this is huge, the levator veli palatini muscle, which is absolutely essential for normal speech and swallowing. Histologically speaking, a normal lip has keratinized stratified squamous epithelium and skeletal muscle. But transition to the soft palate, and you're looking at non-keratinized stratified squamous epithelium.
So how do we classify these in the clinic? For a cleft lip, we categorize it by side. Is it unilateral, bilateral, or that super rare median cleft? And we classify by extent, meaning is it incomplete, where it doesn't reach the nostril, or complete, going right up into the nostril? Keep this in your back pocket. Unilateral cleft lip is highly tested and is for sure the most common presentation. Now, for the palate, classifications are strictly anatomical. It's either soft palate only, hard palate only, a complete palate cleft, or a snaky submucous cleft palate.
All right, on to Section 3, Clinical Impact in Feeding. This is where we see what the baby actually struggles with on day 1.
The clinical reality for these two conditions couldn't be more different. A cleft lip is primarily a visible cosmetic issue. Sure, there's some mild feeding difficulty, but speech, usually totally normal. But a cleft palate? The main issues there are severe feeding and speech problems. These kids get hypernasal speech because of veilopharyngeal insufficiency. Plus, they suffer from recurrent otitis media and conductive hearing loss. Why? Because the tensor veli palatini muscle isn't working right, which means the eustachian tube doesn't ventilate properly. They also end up dealing with missing teeth and severe crowding.
Because of all that, feeding management is quite literally a 5-star priority. Infants with a cleft palate simply can't generate the negative pressure needed for normal sucking, so milk just ends up coming out through their nose. We have to step in immediately. We feed them in an upright position and burp them frequently. We also use really soft nipples and specialized squeezable cleft bottles to manually help deliver the milk. Interestingly enough, though, if an infant only has an isolated cleft lip, regular breastfeeding might actually still work just fine.
Which brings us to Section 4, Surgical Repair and Timing. Get ready, because this is probably the most famous exam pearl in the whole explainer.
The rule of tens. Seriously, if you remember only one thing about surgical timing today, make it this. For cleft lip repair, we wait until the infant hits 3 very specific milestones: 10 weeks of age, 10 pounds in body weight, which is roughly 4.5 kilos, and 10 grams per deciliter of hemoglobin. This isn't just some random medical tradition. This specific criteria guarantees the baby has enough physiological reserve to safely handle anesthesia and surgical stress.
So when that cleft lip surgery finally happens around 10 weeks, what's the surgeon actually doing? The goals are to restore continuity to the orbicularis oris muscle, beautifully reconstruct Cupid's bow, and improve nasal symmetry. As for how they do it, you absolutely have to know the Millard rotation advancement flap. It is by far the most common, highly tested technique for a unilateral cleft lip. You might also hear about the Tennyson-Randall triangular flap, so keep that name in mind too.
Now, palate repair, totally different timeline. We actually delay the surgery until the child is between 9 and 12 months old. The main reason we do it before 12 months is to optimize normal speech development. The surgical goals here are to physically close the defect, rebuild that critical levator veli palatini muscle, and improve velopharyngeal function so the oral and nasal cavities are properly separated. Common techniques you'll see on exams include the Bardak 2 flap, the von Langenbeck, and the Furlow double opposing Z-plasty.
All right, Section 5, Complications and Long-Term Care. Surgery is a massive milestone, but it's really just the beginning of a lifelong journey for these patients.
Obviously, every surgery carries risks. Early complications are exactly what you'd expect: bleeding, infection, and wound dehiscence. But honestly, it's the late complications where the real, long-term challenges pop up. We have to monitor these kids closely for a residual cleft or a palatal fistula, which is highly tested, by the way. We also watch out for velopharyngeal insufficiency, which causes that hypernasal speech we talked about, as well as maxillary growth disturbances and severe dental issues.
Because of those intense, long-term complications, a multidisciplinary team isn't just nice to have, it is absolutely mandatory. We're talking plastic surgeons, ENT specialists, orthodontists, psychologists, and, crucially, speech therapists. These patients usually need years of speech therapy and orthodontics. Oh, and here's a massive exam point. Secondary alveolar bone grafting is often required. When do we do it? Specifically during the mixed dentition phase, right before the permanent canine erupts.
Okay, we've built the foundation. Let's head into Section 6, High-Yield Exam Pearls. Time for a rapid-fire review to really cement these facts.
Let's lock in those foundational differences one last time. Cleft lip, that's a failure of the medial nasal and maxillary processes between 5 and 7 weeks. It's mostly a cosmetic issue and we repair it at 10 weeks. Cleft palate, that's a failure of the palatal shells between 7 and 12 weeks. It causes massive feeding and speech issues and we repair it much later, between 9 and 12 months.
Let's test your recall directly right now. If a multiple-choice question asks for the failure of fusion causing a cleft lip, what is it? It's the medial nasal and maxillary process. For the palate, palatal shelves. What does the rule of tens apply to? Exclusively the cleft lip repair. Most common unilateral lip operation? Millard rotation advancement flap. And what is the actual root cause of hypernasal speech? Velopharyngeal insufficiency. Boom!
Now picture this. You're sitting in a Viva, and the examiner leans in and asks, why exactly do babies with cleft palate have feeding difficulties? Your crisp, confident answer is, the infant cannot generate adequate negative pressure for sucking. Why do they get recurrent otitis media? Due to tensor villi palati dysfunction causing poor eustachian tube ventilation. When do you do the alveolar bone grafting? During mixed dentition, right before the permanent canine erupts.
Here is your final checklist of must-know exam pearls. Number 1, lip and palate arise from entirely different embryological defects and can occur completely independently. Number 2, palate repair happens at 9 to 12 months specifically to support normal speech. Number 3, hypernasal speech always equals velopharyngeal insufficiency. Number 4, recurrent otitis media equals eustachian tube dysfunction from abnormal muscle function. And number 5, successful management absolutely demands a multidisciplinary cleft team throughout childhood.
We've covered the timelines, the classifications, the clinical hurdles, and the surgical rules. But to wrap this all up, I want to leave you with one final thought. How does mastering this exact timeline of early embryology fundamentally change how we approach both the surgical timing and the lifelong multidisciplinary care for these patients? It is just wild to think that microscopic events happening in the 5th week of fetal gestation dictate complex medical treatments that span an entire childhood. Keep that in mind next time you're reviewing this. Thanks so much for joining me in this explainer, and keep that focused learning going.